Right close to me too. All right, so today we'll be talking about fluids and electrolytes. I'll just get when I get to it, I'll get to it. So these are the learning objectives. So if you'll notice, in particular, there are probably I probably don't even have this thing on, or maybe the microphone is not working, and maybe there it is. How about that? I figured it out. So there are a couple of things to especially pay attention to on here. The number 2, estimate plasma osmolality. You can see that's an action verb. So on the exam, I'll have you do it, but we'll do some practice stuff in the class today. And the rest of them are all mapped to exam items, so they should help you in your studying. What we are covering and what we're not covering, because there's a lot of material here that if you go to Access Pharmacy and look at the Puro Pharmacotherapeutics textbook, you'll see a lot of, it's in the renal section is where fluids and electrolytes are, because there's a lot of overlap between those two topics. So because of that, I'm in particular not covering certain things that might appear in those textbooks, and it's because they will be covered in other areas. So what we will be covering is most of chapter 70 in the book, which is sodium and water homeostasis. We'll talk about that at the beginning and towards the middle. And then we're also going to be covering potassium. So the chapter 72 is potassium and magnesium. They're very closely related to one another in the sense that they're both positively charged cations, but they are different in the sense of how we deal with them clinically. So I'll cover some of that in potassium, but I won't cover the intricacies of magnesium. You will get that in some of the renal stuff that you do. So that's calcium and phosphorus is another area that we're not going to cover. So calcium and phosphorus are very closely regulated by kidney function. So that's why we're not covering them in today's lecture. All right, so first off in the fluid area, so I mentioned we're going to talk about sodium and water homeostasis first. These are some concepts. You might remember them from biology, or if you took some kind of undergrad physiology before you got in, and you also took the physiology that was here. We have some spaces in the body, and spaces are a helpful way for us to think about where water is and where it is not, in terms of both the electrolyte content of the water, as well as the fluid distribution that the water has. So the biggest compartments are the largest distinction here. Where did I put this? The largest distinction here is between intracellular and extracellular. So intracellular is obviously inside the cell. Extracellular is all the fluid that is in the body outside of the cell. The extracellular fluid is actually something that we have a lot better likelihood of seeing or being able to measure the contents of it, because it's outside of the cell, because we can't really get inside the cell. So we have, of the extracellular fluid, we have two different types or two different classifications. The most common or the most familiar for us is the intravascular fluid, because that's what's in our blood vessels. So our blood vessels contain all the electrolytes that we measure, in the sense of when you get blood drawn, that's intravascular fluid. So that's really important. When we talk about blood pressure, that's intravascular. And so we know we need to perfuse our brains, our heart, our kidneys, all of our other vital organs. And so we do that via intravascular fluid. So in terms of where the body water is, most of it is inside of our cells. So around about 2/3 of all of our body water is inside of our cells, and the rest of it is located outside of the cell, so that intra versus extracellular. And only a small part of it, so only 1/4 of the extracellular fluid is actually in our blood vessels. So a very small minority of the water that we have in our body is what we consider our blood, or consider the fluid that's in our blood vessels. So there's a lot of fluid outside of the blood vessels and a lot more inside of the cells. So that helps us in terms of thinking about how, when we get to some of the treatments for things, we're going to talk about moving electrolytes in and out of cells, and that's why that's important, because the cells contain water, and so we can look at how that balances out with our different treatments. So over the course of our age, so when we look at the difference in total body water as we progress through life, most of an infant, as soon as they're born, most of the content of their bodies is water. That changes drug distribution. So you will cover that when you get into pediatrics. Have you already had pediatrics? No, you'll have that in winter, I believe. So, oh no, sorry, pediatric like therapeutics. So there's a couple of sections of like cystic fibrosis and things like that. But the important part of that is distribution differs in young people versus older people. Not just older as in like older adults, but like adults in general. So most of an infant. So if you look here at the total body water, so at 2 months, over 90% of the infant's like the whole weight of the infant is water. That progressively gets lower throughout time. And so this is what we're probably familiar with. Around 50 to 60% of our body weight is water as we get into adulthood. So what does that mean? It actually affects your volume of distribution because, as you recall from pharmacokinetics, volume of distribution is the size of the tank relative to the weight that a drug distributes into. So why that's logistically important for us is that since the distribution in infants is much higher, the weight for weight dose of a lot of drugs is higher. So when you get into dosing like antibiotics, especially like weight-based antibiotics, so treating something like acute otitis media in children and infants, you would do a weight-based dose. If you were to do that same weight-based dose in adults, it would be way more than what you would typically give. And that's how I remember that volume of distribution is most impacted by age and in proportion to the weight. So since volume of distribution is how much drug distributes into the body, lower body water equals less drug distribution, and higher body water equals higher drug distribution. All right, so osmolality, this is a review. The concept of osmolality is a measure of how many particles are dissolved in a given solution by weight. So we use osmolality because while we do displace volume, not all of us get into like a calorimeter or one of those like distribution tanks to see how much water we distribute away or how much water we displace, which would be a way to measure volume. So what we do is we weigh our patients, and that tells you how much the weight is of all of the contents of the person. And so we look at also the fact that specific gravity, so you remember specific gravity and that type of thing, it's generally consistent from person to person. That's why we can give blood products and IV fluids to different people. It's because it's all tightly regulated within a range. So we look at osmolality as opposed to osmolarity for that reason. When we look at higher versus lower osmolality, we're looking at more particles dissolved in a given solution compared to fewer particles dissolved in a given solution. Our general normal plasma osmolality is somewhere between 275 and 290 milliosmoles per kilo. I say the part about weight-based because milliosmoles per kilo is not the same as milliosmoles per liter. It's just a different way to think about it, and it's more practical for us. So like a higher osmolar solution on the right-hand side is more particles. So if you can see, it's the same amount of fluid, and so you have more particles dissolved in it. So estimating osmolality, as I noted when I went over the objectives, that's something that we're going to do. One of the ways I remember this formula in particular is thinking about if a normal person is in front of me, like a non-critically ill person, because that's what I'm used to taking care of in the ICU at the hospital, would be something, so that person who has normal lab values, I would assume would have normal osmolality because there's nothing disrupting it. So the three main factors or the three main parts that go into our estimation of plasma osmolality are sodium, glucose, and BUN. So that's reflective of sodium, which is the most abundant extracellular cation, positively charged. And then glucose is a active. So remember, glucose, the molecule is kind of slightly polar. So it like pulls a little bit on one side of water and pulls a little bit on the other side of water. That's why it can dissolve in solution, is because of that polarity. But it also has osmolar activity. It has activity as a particle in solution. And so we attribute some of our osmolality to that. And then the last one is protein. Protein is very similar in the sense that it has some charge on one side of it and another type of charge on the other side of it. So it's attracted to water, and that varies based on the amount of water present in other factors. So we would take those three and we would use that to estimate osmolality. So in this case, the example I give you, normal values 135, 20, and 90. Those are just kind of values I threw out there. So the formula it's called the Dorwart and Chalmers formula. It's two times the serum sodium plus the glucose divided by 18 plus the BUN divided by 2.8. So that is the basically contribution of those factors towards osmolality. I won't go into how it's derived, but it will be something that I want you to be able to recall and use on the exam. It's something that's very quick. It's something that you can look at the numbers and figure out kind of roughly where the patient's osmolality is based on that formula. So in this case, 2 times 135 plus 90 over 18 plus 20 over 2.8, 270 plus 5 plus around 7, and you get around 282. So those are normal values, and normal lab values lead to normal plasma osmolality or normal estimated osmolality. When we get into some of the other disease states that I will actually teach you later on in the year, I will refer back to this because there are some disease states that affect osmolality. And so, for example, if you had a calculated osmolality of a certain amount and then your estimated is very different, that means that there's other things in the patient's serum that contribute to their osmolality. It could be something like diabetic ketoacidosis or some other kind of disease state that is going on. So our first knowledge check here, which one of the following values is within normal range for human plasma osmolality? This is exactly the type of question I would give you on the exam. I would either have you calculate it or I would give you this and I would say what falls within normal range. So who says A? All right, who says B? All right, who says C? Yeah, who says D? Fantastic. So correct answer is C. So we got that 275 to 290. That's where to put that here. Yeah, 275, 290. All right. So another kind of review topic is tonicity. So we might hear that in a lot of different settings when it comes to remembering biochemistry and things like that. I know you probably thought, I thought we finished that, but we never really finish things like that. We always refer back to them. That's why they're foundational sciences. So the thing that I want you to remember about tonicity here is that tonicity is always relative. And what that means is that it's always relative to comparing what the contents of the solution is to some other type of solution. So iso means same, so isotonic means the same tonicity. So I'm comparing one fluid to another fluid. They have the same tonicity. Tonicity, if you don't remember what that is, this is a great quick review that goes over all of the concepts that I've talked about before. So osmolarity, osmolality, and tonicity. I would take a look at that if you're not remembering this from other stuff that you've learned. All right, so I mentioned that it's relative. So we have our first on the left here, solvent and solute. So we know that solute is what is dissolved in solute or solvent. So in an isotonic solution, you have roughly the same concentration of solute compared to the solvent. So it's something that there's a lot more. The relative concentrations of the solute and the solvent are the same in that given volume. Hypertonic solutions have far more solute than there is solvent. So that is higher, higher. So higher concentration of solutes. And then the last one is hypotonic. And hypotonic is hypo, lower. So lower concentration of solute compared to the solvent in that given solution. So those are the three broad classifications. Practically, we're going to use this as we get into more of the treatments for fluid and electrolyte deficiencies or for deficits. But isotonic solutions are, because we said isotonic is the same, they're generally considered the gold standard for replacing volume. So if a person has blood loss or they're dehydrated and they need additional volume, isotonic solutions are generally considered the gold standard for volume replacement. So in that case, remember that the similar iso, so iso same, iso similar, is very similar to human plasma. Hypertonic solutions have a higher solute concentration than the plasma. So when you administer a hypertonic solution, you're administering something that has a higher concentration of solutes compared to the blood or the fluid that it's being administered into. We do use hypertonic solutions less frequently than isotonic solutions, but far more than hypotonic solutions. One of the ways that we do use hypertonic solutions is in severe hyponatremia, and I'll get into that as we go forward into the treatment of sodium disorders. But it is also a very careful use. It's not something that's arbitrarily used. It's not something that's stocked and people use it all willy-nilly, just like you would an IV fluid in a hospital, a general IV fluid. It's something that's used very specifically and judiciously. Hypotonic solutions, on the other hand, since they have a lower concentration of solutes than human plasma, they're typically seen as the base for other IV fluids. So for example, if I was giving a patient, I needed an IV fluid that had potassium in it. Potassium has a charge, and so that charge is going to generate pressure when it's administered into a person. It's going to generate like a charge interaction. And so I might administer D5, which is dextrose 5% in water, plus 20 of K, or D5 half normal saline with 20 of K. That, if I do the math on those things, I can figure out what the tonicity of that solution is compared to what my human plasma is. So hypotonic solutions can be used in just a really small number of circumstances, but mostly they're used as the base IV fluid for some more complex or more mixed electrolyte solutions. So this is a chart from the pharmacotherapy textbook. I really like the way that it compares the different IV fluids to one another. So if we go down the list here, we have the most basic IV fluid is dextrose 5% in water. Do you recall what the 5% means? Remember what 5% means? 5 grams in 100 mils. So that was something that caught me off guard when I was in school. The way I remember that is per cent. A cent being century, 100. So per 100. So 5 grams per 100 of whatever. So the kcals, since dextrose has calories in it, if you notice none of the rest of them do, 50 kcals per liter, then it doesn't have any of these other components to it, but it does have some osmolarity. Why does it have osmolarity or osmolality in the case of the weight-based part? It's because dextrose has a charge interaction. So dextrose is slightly charged, slightly polar because of the structure that it has, and so it generates a type of pressure in the intravascular space. One of the nice things about it is while it has some charge, this is lower than human plasma osmolality. We already talked about that. So that means I can use D5 as the base for other electrolyte solutions, which I do, and we do pretty commonly. So when we add other electrolytes to D5W, we can actually make it closer to human plasma osmolality, and we can administer whatever electrolytes we want. So if we can do D5 with 20 of K, like I mentioned before, that's actually going to provide potassium to the patient and get closer to being isotonic. So quarter normal saline, you might see similarly to D5W as the base fluid for mixed electrolyte solutions. So that's called quarter normal saline, so 0.225% sodium chloride. And this is the milli equivalents or millimoles per liter for each of those. And then if you look at the osmolality, that's what it adds to it. So if you were to add, if you were to take D5W and add quarter normal saline, which you probably wouldn't do, because it would be pretty hypertonic at that point. But it does, it is considered on itself hypotonic, so it could also be the base fluid for a larger mixed electrolyte solution. Half normal saline, 0.45%, has, sorry, I have to use this pointer because as you recall, I have janked up shoulders and I can't really point. But this is similarly, it has sodium and it has chloride in it, and it's also hypotonic. Normal saline is what we're probably most familiar with. If we have ever received IV fluids, like when I had my surgery, I got IV fluids beforehand, it was normal saline. So most IV fluids that you would see are normal saline. It's the typical, like kind of gold standard IV fluid. It is considered isotonic, even though it's slightly above the normal range. It's considered isotonic to human plasma. Interestingly here, so this chart tells us where does that fluid go. So we want, if we're trying to give someone resuscitation, we're trying to give them volume because maybe they've bled out or maybe they're dehydrated. I don't want the fluid to go inside the cells. If it went inside the cell, it doesn't help me if they're low on fluid or low on volume outside of the cell. So I really want all of that fluid to stay outside of the cell. And so in this case, normal saline distributes 100% in the extracellular space. It doesn't fully distribute into the intravascular space. That would be super convenient. It goes into the interstitial space, which is the space between the cell and the blood vessels themselves, but it does not go inside the cell. Lactated ringers is a mixed electrolyte solution in itself. It's got some sodium. If you notice, it's got a little bit less sodium. It's got a little potassium. It's got a little less chloride, but more than it does potassium. And it also has lactate calcium in it. So it is designed to be isotonic by definition. So what I learned in school was that this was used most commonly by surgeons or in the operating room to replace blood volume. That's not necessarily true. It does tend to be used more frequently when patients need replacement of volume when they have had loss of blood, but most of the time you'll still see normal saline unless otherwise specified. The reason for that, logistically, in particular in emergent situations, is the lactate and the calcium can actually interact with some other chemicals. If you think about how you could get a precipitate or something like that, you have a higher risk of that happening when you have other components in the solution so like if you're administering in an emergent situation, you don't know what else is in the patient's bloodstream already. So that could be something that it's a lot harder to use it in an emergent situation because there's just a little more risk with it. The other not the very bottom, but the ones that are after that, Plasmolite and Normasol, those are branded, patented, like trademarked IV fluids. When I was in school, we had some surgeons I was in the trauma ICU, we had some surgeons that preferred Normasol. As you might imagine, it's more expensive because it's branded, and the data is kind of limited on the efficacy compared to normal saline. But the difference is in the relative concentration of the different electrolytes. So for example, Plasmolite has a little more sodium, has a little less chloride, and it has actually magnesium in it in addition to some glucose. So it's different. And the question comes up, is it different enough to justify the cost? And that is still to be seen. There aren't a ton of studies that use these branded solutions as a variable. But doesn't mean that you won't go into practice or you won't see it when you're on your appies, like one of the surgeons or one of the attendings may prefer Normasol or Plasmolite. But you'll probably have the same types of discussions about the relative cost of those compared to normal saline. All right, and the last one is hypertonic saline or 3% sodium chloride. I'll get into that when we talk about the treatment of hyponatremia, but it is very specifically used in certain situations to treat hyponatremia, or in an extreme situation like on the battlefield, they can use that as a resuscitation fluid, but it's in very rare circumstances that it's used that way. All right, so this is a graph I found. It's got the broad classifications. This got the same information that I talked about before: hypotonic, isotonic, hypertonic, and then the last one that we haven't covered yet are colloids. So all of these up here are considered crystalloids. I don't really know the crystal part of it, but the way I remember it is crystalloids use ionic attraction or ionic, like polar interactions, to generate the pressure inside the vasculature. Colloids use large molecules that can't be broken down. So glucose is not a large molecule that can't be broken down because our bodies can break down glucose, but something like albumin is not able to be broken down as easily by the body. So when we give it into intravascular space, it still has that charge interaction with the rest of the fluid inside the vasculature. So as I noted before, colloids are complex molecules that cannot be broken down easily by the body, so that provides osmotic pressure or oncotic pressure that in some ways is actually helpful, because since it can't be broken down easily, remember, one of the basic premises of chemistry, water moves towards solutes, so across a semi-permeable membrane. Our blood vessels are semi-permeable membranes, so if you create a larger concentration of solutes inside the blood vessel, you're going to pull fluid in to the blood vessels. So that's actually not a bad thing when it comes to if we're using it intentionally for that effect. So one of the bigger things that, let's say a person is bleeding out, but they're also edematous. So they have, they've had a car accident or some kind of other trauma. and they are bleeding out, but the body is swollen because of the IV fluids that they've been given in the field. That's kind of like, well, what am I supposed to do? Because if I give them more IV fluids, they're going to continue to swell, and that's not good for the patient. So what we do is we think about the indications for using albumin, and one of them is patients that are on fluid restriction, so patients that have heart failure or some kind of other issue that causes them to need not as much fluid as you would normally receive on a weight-based amount. Or patients in that example that I just gave, the patients that have received a large volume of crystalloids. So someone has had an accident, they've gotten IV fluids in the field, they come in and they need continuous fluids because their blood pressure is still low. If you give albumin in those situations, it actually pulls that edema fluid into the blood vessels, and then it can be eliminated by the body in the kidneys. So another way that I've seen it used is when, in that exact example I gave you, the name for this was a albumin Lasix chaser. So we would take people who were edematous, and so it was. I just, as an aside, I worked in the trauma ICU when I was in my residency, and we would see people, like I'd come in the morning and there'd be a person who was in the hospital bed, and they'd have their image from their driver's license up, and they looked nothing like it because they had received so many IV fluids. They were puffy and edematous, and it's because of that distribution I was talking about before, where a lot of that fluid went into the interstitial space. Well, that albumin Lasix, so albumin, give albumin, the water moves into the blood vessels, and then the Lasix or furosemide accelerates the elimination of the fluid. So you actually pull fluid in and then you eliminate it. You pull fluid in and eliminate it. It's not fantastic that you have to do that, but if the alternative was them dying because they didn't have enough volume, then it's a certainly a cost benefit analysis that errs on the side of giving it. So that is this concept of pulling fluid into the vasculature. So colloids can pull fluid from the interstitial space into the intravascular space, and then it can be eliminated by the kidneys that way. The kidneys are not going to eliminate fluid that they don't receive. So if the fluid is stuck in the interstitial space, they're just not going to receive it. So you're just not going to eliminate it. Another important factor is the one I have on the bottom here. Albumin is a part of the labs that we gather. And so when a person has low albumin, what do you all think causes low albumin? So where, if you remember, where is albumin made? Like how would someone have a low albumin kind of naturally? Liver failure. So when in doubt, always answer the liver. So where is albumin made? The liver. What makes albumin? Proteins and nutrition. So a person who has low albumin, who is otherwise healthy in the sense of like they're not injured, they don't have like a blood loss or something like that, because you could have bleeding that could lead to low albumin, but it's also going to lead to low everything else. It's not going to be an isolated low albumin. You'll talk about in nutrition pre-albumin. Pre-albumin is a early, it's like one of the initial because most of these complex proteins have like 7 steps in their synthesis. So pre-albumin is the earlier phase of synthesis. So it tells you if the person is receiving appropriate nutrition or not. So giving albumin to correct a low albumin would be like a person who is septic, having an infection, giving them Tylenol to treat the infection because it causes a fever. If you don't give the antibiotics, you're really not going to get rid of the infection that's causing the fever. So it's really treating the provider as opposed to treating the patient if you give albumin, if a person has a low serum albumin. All right, so how much fluid do we require per day? Well, like a lot of things, there's a rule of thumb but it's actually not, it's not as arbitrary as it sounds. There's a lot of background chemistry that goes into it, but it's something that we can remember and something we can use. So the rule of thumb for adults is 1,500 milliliters of fluid required for the first 20 kilos, and then 20 milliliters per kilo thereafter, based on actual body weight. I have a little caveat there that it's based in a clinical situation. Always look at the patient, because the example I just gave you about a person who is really edematous, so they've received a lot of fluid already, that person may not need as much in the first 48 hours after they're stabilized because they have a lot of fluid already on board. So their requirements might be slightly different than a person who is of normal volume and just requires the same type of maintenance fluid. So let's say someone has pneumonia, they're not edematous, they get admitted to the hospital, they need to figure out how much fluid they need per day. That would be kind of a general situation to use the rule of thumb. The other kind of questions I have are, what if the patient's current weight is not their normal weight? So think about a patient that has heart failure. So heart failure is where the body retains fluid. And so since fluid weighs more than what not fluid does, it doesn't weigh as much as other things, but it would cause the patient's weight to be higher than normal. That's a clinical decision. So when you have a heart failure patient, typically there's something called their dry weight, which is when they're not overloaded. That's what they would normally weigh. And then they have their wet weight, which is what they are when they are retaining too much fluid. So the other questions, were they dehydrated? Did they have trauma? All those types of things that I just mentioned before. It doesn't mean that you have like another mathematical way to determine what you should administer, but what it does is tell you on which side of the estimation you should be. So if the person, so you do your math and you estimate that they need X amount of milliliters per day. If they're overloaded, you would be on the low end of that. And if they're dehydrated, you might be on the upper end of that, whatever that range is. So let's take our first example calculation. So RR is an 89 kilo male in the ICU. Calculate his fluid requirements using the rule of thumb. So we have first the 1500 mils per kilo. So that's 1500 for the first 20. Try my best here. 1500. And then 20 mils per kilo thereafter. So what we do is we take the patient's weight, we subtract 20 from it. So 89 minus 20 is 69 kilos. So someone do 69 times 20, 1380. All right, so we add 1380 to 1500 and we get what? 2880. So, woo. This is like me signing on like a little thing at the pharmacy or something. Ain't got to be pretty. 2880. So there we go. All right, number 2. TY is a 55 kilo female on the med-surg floor. Calculate her fluid requirements using the rule of thumb. So I won't write on the thing for this one, but 1500 for the first 20. So then if we take our 20 mils per kilo thereafter, so we take 55 minus 20, that is 35. 35 times 20 is 700. So 1500 plus 700 is 2200. All right, so those are 2 example problems. I will have you do that on the exam, so they'll be very similar in nature. All right, pediatric fluid requirements. I've had this photo in this lecture since I first started here in 2010, and I love it. I love this baby picture there. But there are different fluid requirements for infants and children. As we discussed before, since infants are mostly water, their fluid requirements are higher proportional to their weight. So kilo for kilo, generally higher. Another reason is that since their livers and their kidney are immature, they're not able to conserve water as much, meaning when we have hormones that we make that conserve water, so we save it if we're dehydrated, or we can eliminate it more rapidly if we're overly hydrated. But infants have a less ability to preserve water, and then their insensible losses are higher. Insensible is things like sweat and breathing, so they actually breathe off more of their water and they sweat more of their water proportionally because their skin is thinner. So you got a lot of different reasons there why infants and children have a higher weight per weight fluid requirements. So the formula that goes for that one is the Holiday-Seeger formula, the Holiday-Seeger method. The difference, it actually is similar on the low end, on the 20 mils per kilo end, but it's proportional to weight is much higher on the lower end. So it's 100 mils per kilo for the first 10 kilos of body weight, then 50 mils per kilo for the second 10. If you do the math, what does that lead to? That leads to 1500 for the first 20, which is the rule of thumb. So it's almost like a derivation of the rule of thumb, but for the first 20 part, because obviously infants and children weigh less. So then the 20 mils per kilo thereafter. So let's do an example problem here. FR is a 14-day-old infant male in the NICU. He currently weighs 5 kilos. So calculate his fluid requirements. So we would do, since he's in that less than 10 range, we would do 100 times 5, which is 500 mils. So that's this FR's fluid requirements, 500 mils per day. All right, so PE is a 28-day-old infant male admitted to the general floor, currently weighs 16 kilos. So calculate the fluid requirements. So we would do 1,000, since that's 10 times 100 mils per kilo for the first 10, so we do 1,000. Plus, he's 5 kilos over, or sorry, 6 kilos over 10 kilos. So 6 times 50 is what? 300. So 1,000 plus 300 is 1,300 milliliters. All right, so now switching gears, we talked about fluids. Now we're going to talk about electrolytes. So I got my picture of Pedialyte there. It's great, and it sounds like it's not for adults, but it really is for adults. It's a very great, it's a very good fluid replacement for people who can drink. So first we'll talk about sodium. Now sodium is, as I noted before, the principal extracellular cation. So extracellular means outside of the cell, and cation means positively charged. So it's got a +1 valence. The concentration of sodium is very tightly regulated. We have lots of different mechanisms for regulating our sodium balance. They are part of that homeostatic system or homeostasis system that we have that keeps everything within a normal range. And so when we disrupt it, typically there's a lot of other stuff going on that would cause a dramatic disruption, usually to the other homeostasis components. Vasopressin or antidiuretic hormone is very tightly, that's closely tied, the release of it and the regulation of it. The link I have there is to a pretty good physiology review that helped in the past with students who are having trouble understanding vasopressin and remembering that physiology. So if it's something that you're like, I don't remember that, go and take a look at those resources. But disruptions in sodium balance are also tied to the alteration in the concentration or the ratio between sodium and water in the extracellular fluid. So I'll get into what I mean by that in a bit, but the concentration, remember, this is a concentration thing. So if I take the same amount of solute and I dissolve it in less solvent, then it's going to have a higher concentration. If I take that same amount and dissolve it in a larger amount of solvent, then it's going to have a lower concentration. So the amount of sodium isn't as important as the overall balance of the fluid that it's dissolved into, because the concentration is what's being regulated. When we get into where the normal range is, since we're 135 to 145, that is a tight range. It may not seem like it's a tight range, but remember, it's a pretty big number. So 100 or close to 150 versus like your potassium is in that 3 to 5 milliequivalents per liter range. So a normal range of 10 milliequivalents when you have a large amount of sodium like that is a relatively smaller range. So over 145 is considered hypernatremia or above, and below 135 is considered hyponatremia. So also starting out with low sodium as a disease state, so it's considered hyponatremia, is a sodium less than 135. It is a pretty common electrolyte disturbance in hospitalized patients. There's a lot of different reasons for that. A lot of them having to do with the reason why the patient's in the hospital in the first place. So remember, you don't get admitted to the hospital if you're otherwise healthy. So that isn't to say that it is caused by the hospital or anything like that. It's just observed more frequently in hospitalized patients. One of the important distinguishing characteristics is to figure out whether it's chronic in nature or acute in nature. And what I mean by that is, did it come on suddenly, or is it something that slowly developed over the course of time? Our bodies tend to accommodate and account for things that happen very slowly over the course of time. That's part of homeostasis. It's why hypertension can exist. Hypertension doesn't come on very quickly. It usually develops slowly over time, and the body becomes used to that higher blood pressure as a part of its normal physiology. So that will help us when we decide or determine if it's chronic or acute. That'll help us decide part of our treatment regimen for it. The other thing to consider is, what is the overall fluid balance of the person? So are they over, are they edematous? Do they have too much fluid? Do they have not enough fluid? Because if they have, as I noted before, the same amount of sodium dissolved in a large amount of fluid would give you a low concentration. That same amount of sodium dissolved in a low amount of fluid would give you a high concentration. Another kind of distinguishing characteristic is, how fast did it happen, and then where did it end up? So the low sodium, we get down into 125. We're getting into this neurological symptoms, nausea, vomiting, tiredness. Why do you think we get tired when we have low sodium? Does anyone have any idea about that? Very good. So, used for transmission of nerve signals. So, you don't transmit your nerve signals as easily when you don't have the amount of sodium that you need. Because remember, sodium goes in, potassium goes out. That's how nerve signals are transmitted. So the further that you get into the low range, and again, this is concentration, so it doesn't always mean the pure amount of sodium that's present. You get into really significant neurological symptoms, tremors, loss of coordination, delirium. So that's like mental status changes. Then when you get into the 110 to 115 range is when you're concerned about coma, seizures, and even death that comes from that. As I noted before, since it's something that we see a lot, depending on disease state, like a heart failure patient may have a low serum sodium, that may be something that is asymptomatic for them. So they may get admitted to the hospital with a sodium of 126 or 123, and they're otherwise fine. It's because their body has adapted to that low sodium over the course of time. It doesn't mean that it doesn't need to be treated, but it means that the symptoms might not be as severe in the acute phase because the body has become adapted to it or become part of the homeostasis for those patients. So the mild to moderate versus severe classification of symptoms is very important for determining what we do for treatment. So mild to moderate is when you get kind of general symptoms, so that nausea, vomiting, confusion, slight headache, that can happen with, that's considered mild to moderate. But when you get into the severe range, you get into the intense abnormal somnolence. So that's like I really can't move that much at all. So a person who's extremely lethargic, they vomit, they're in cardiorespiratory distress. They can, as I noted before, get seizures. And then you get into a GCS, so Glasgow Coma Scale. Who's heard of that before? GCS? Okay. So GCS was something, this is something I do because I don't want you all to be like in your IPI or your API and like, I don't know what GCS is, because they're going to say it all the time. So GCS is the Glasgow Coma Scale. It is 3 different characteristics: eye-opening response, best verbal response, and best motor response. So eye-opening response is if I were to walk into a room and you hear me and you open your eyes. That is spontaneously, meaning it didn't require anything for you to open your eyes. To speech means that I have to say, hey, and then you open your eyes. So that's a 3. To pain means that, I tried. This is actually, if you go online and watch someone doing a GCS, they walk in the room, they start speaking to the person. They do all this in sequence because it tells them what the score is. Because if they go in and they say, hey, Mr. Jones, he doesn't wake up, it's already not a 3, right? Because the speech didn't work. Then he says, hey, you touch him, and it doesn't wake him up. Then you have to induce pain. So what do you think they do for pain? Yeah, it's not fun. But that might wake you up, right? Like if you were, so let's say that didn't work. They pinch. So there's 2 different things. There's a sternal rub. So take the knuckle, like your middle finger knuckle, and you rub it on the sternum. That's a sternal rub. Do it to yourself. Oh, that kind of hurts, right? So the other one is you can pinch the underside of the arm. Yeah. You pinch the underside of the arm. Ow! Right? Like that'll wake you up. So if that worked, then they get a 2 for that, right? Because they didn't wake up spontaneously and they didn't wake up to speech. So if that doesn't work, then they get a 1. There's no response to eye opening. Verbal response, you ask them questions. So you go in. So again, I'm going in, and this is like, they do GCSs all the time. The more a nurse or a physician is used to it, they can do it without even saying like, I'm about to do a GCS. But they go in and they talk to the person. If they open their eyes spontaneously, that's a 4. If they say, hey, Mr. Jones, what day is it? Okay, it's Sunday. It's not Sunday, it's Wednesday. Then that was not appropriate, right? So they start asking questions. They say if they're oriented to time, place, and person. So you've heard that before, that someone says, where are you? What's your name? And what day is it? Those are time, place, and person. If they mix up some of those, like if they don't know who they are, that's tough because sometimes people can be confused about like what they're supposed to be saying at that given time. Then you would take away points from it. Sometimes, and I've seen this in practice, inappropriate words, they'll say like gobbledygook. but they're telling you, they're like saying it, and they're confident that they're saying it. That's an inappropriate word. If they're not comprehensible, so like instead of saying words that don't make any sense, they just say sounds, then that is a 2, and if they don't respond, then it's a 1. So the last one is motor response. So this is another thing. Again, they're doing it. Say, hey, squeeze my hand. So they feel it, they can squeeze whatever hand it was. Squeeze my left hand if they're holding both of their hands, or lift your right leg up. Let's say that they were paralyzed and they couldn't move their arms. You can say lift your left leg up, or whatever it is that they need to do. Then they're considered following commands. You might have heard that before. I remember on rounds, the first couple times I was in the unit, they would say, okay, bed 16, that's Mrs. Smith, she's following commands this morning, so and so. That's how they do it. That is what that means. They're following commands. So what is the lowest score that you can get? 1, 1, 1. The lowest score is 3. So 3 is considered to be a candidate. So persistent GCS of 3 is considered to be a candidate for organ donation. Persistent means like over the course of several times of doing it. So maybe like a day or something of a GCS of 3. You're considered comatose, you're in a coma if your GCS is 8 or less. So how do you get an 8? Well, if you look at it, you have to have, so if you have all of these motor commands, but you have no verbal or no eye opening, then the highest you get is a 6. So essentially you need to get some of these. You have to get some of them to not be an organ donor, to just be in a coma. And I mean not an organ donor candidate. That means someone is brain or at risk of being considered brain dead if their GCS is 3 consistently. And then the best response is a 15. So what we typically see is someone GCS is like 13 or something like that, and that's not great, but it's okay relative to being 8 or less. So coma. This is the other thing I think, just from an ICU perspective, is I always hear patients are in a coma. You hear that? That actually does mean something. So so does they're following commands. I always thought, why do they keep saying they're following commands? It's because so that's why I include this in this lecture, because I was sitting where you all were when I was in school, and I'm like, I don't understand what any of these words mean when they say that. So when you're on rounds in the ICU, you'll hear the nurses and the physicians say, they're in a coma. That's what that means. If they are following commands, that's what that means. Now, what's one of the caveats here? So what happens? What a lot of people that are critically ill, what do they have going on with them? Well, they could have a stroke, and that's actually a good. Yeah, no. So strokes, there's a different stroke scale that they use for that, but that could affect their speech, right? So they wouldn't be able to talk. But what else can affect your speech? You had a tube, right? So if you're have an endotracheal tube, so they're intubated, right? That's the machine is breathing for them. What we see in those circumstances, because they can't verbalize anything, right? Like they just can't do it. So they'll do one of two things. They'll have them write things if they're able to write. So sometimes people have really bad handwriting, or they're otherwise not able to write. Or they will have them verbalize via like grunts, to say, like, because you can make sounds, but they're not great when it comes from the endotracheal tube. The other thing is that they will not assess that, and they'll put, like in this case, since this is a max of 5 here, they'll say 10T, 10T. So 10T means they couldn't verbalize because they're intubated, but they had the maximum score on the other 2 areas. So I've seen that before in the notes. So that's what that means. To me, I thought that was pretty helpful. So let's go ahead and take a break. We'll circle back at 2 o'clock. Here, and then go back. All right. Yes, and I was about to pass that around. Okay. So we talked a little bit about hyponatremia and the symptoms for that. So I have a highlight here under severe, because we will come back to severe symptoms of hyponatremia and what that leads to in terms of your treatment choice. Other couple of caveats about measuring serum sodium is that there are other things in your blood that can interfere with the way that the assay measures the sodium. The most important one, and probably the most relevant one for what we see in practice, is glucose. So when someone has elevated glucose, so as we said before, the osmolality is affected by glucose. So really high glucose can cause like a hypertonic, basically state of existence in the blood. But since the hypertonicity component suggests the presence of something else in the blood besides the things that we would typically think are there, hyperglycemia is that most common cause. There is a correction factor. It's not something I want you to memorize, but it is actually pretty straightforward. So for every 100 milligram per deciliter rise, the serum sodium decreases, or the measured serum sodium decreases by about 2. So the formula on the bottom is a way to ascertain that. So if you had like a glucose of 500, so that's 500. So 500 minus 100 is 400. So 400 over 1 is 4. So that's basically a factor of 4 times 2. So that's you would have a serum sodium that would be measured to be lower. So, but it's actually higher. So that's a correction factor. I've been in situations where someone comes in and they're in diabetic ketoacidosis. So they are, like a type 1 diabetic who has a blood glucose of like 1600. Thank you. Has a blood glucose of like 1600 or something like that. So their serum sodium on their BMP or on their Chem7 was actually low. But if you did the correction, it was not low. And so that's how I kind of remember that is that person comes in and they are you think that they're going to have a low serum sodium, or sorry, you don't think they're going to have a low serum sodium, but they do. You could do a correction factor for that. Sorry. Having trouble. All right, so the next one is osmolality. So there are 3 different basically classifications of osmolality that would be present, as we have discussed: low, normal, and high. So low osmolality is somewhere less than 280. So remember, the normal range is like 275 to 290. So when you get into the low osmolality range, that's considered hypotonic hyponatremia. And since the hyponatremia component is a concentration, then the low osmolality component would be excess total body water relative to solutes. So basically, the tank is too big, there's too much fluid that's present, so that's a hypotonic hyponatremia. Normal osmolality, so one of the things that is deceiving about the osmolality component is if you have those other factors, so you have a high glucose, you have high proteins in the blood, which can also disrupt the measurement of the serum sodium. What happens is the sodium gets partitioned into a different phase, and it's not able to be measured by the lab. So that's called pseudo hyponatremia, because once you do your correction factors, as we talked about before, then the serum sodium might be within normal range. I'll tell you, I had a patient. I was on an internal medicine rotation. We were consulted to go to the ER, so we all went down to the ER. And this patient was admitted directly from their doctor's office because they had blood work done, and the blood work showed a serum sodium level of 107, and that's death. You shouldn't be alive with a 107. But the lab noted that the blood was milky, and milky means that it had too many triglycerides in it. So triglycerides are type of protein or type of structural component that creates a different partition phase in the plasma. So there's a correction factor for protein, there's a correction factor for triglycerides, which is what that is. There's also a correction factor for glucose, because that person also had elevated glucose. Their glucose was around, I think, 1800. So once we did both correction factors, the serum sodium was actually normal, which is why they were not symptomatic, which is why they were alive and talking to us. So that's how I remember that one. It's called pseudo hyponatremia because it looks like it on the lab, but once you measure it, it isn't actually hyponatremia. So the last one is high osmolality. That's called hypertonic hyponatremia, and that can come from the presence of something else creating the excess tonicity. So because of the interference in the lab assay, let's say that glucose was really, really high, that sodium would be low, but because of the tonicity, because of the estimated osmolality equation, if you recall that, then their actual sodium is low, but their tonicity of their blood is high. So that's called hypertonic hyponatremia. So this is a graphical representation of that. So you have normal serum here, and then this is in a hyperlipidemia state. So that's what I was saying with the triglycerides. the sodium actually partitions into the other phase. This is what we measure. We can't really measure the sodium in the lipid or the protein phase of the plasma. All right, so this is seemingly a complicated flow chart, but it has to do with all the stuff we've talked about so far. So the first thing you look at is serum osmolality. So that's something you can either estimate or you can look at the lab, because the labs will have estimated osmolality on them. If it's normal, then that would be, so isotonic hyponatremia, that would be considered pseudo-hyponatremia. If the osmolality is elevated, then you look at all the other factors that could cause the elevated osmolality. So that's hyperglycemia, the protein concentration, that type of thing. So then after that, that decides whether or not you pursue the therapies that we're going to talk about on the next slide. Then if it's low, then you go into what volume status you're in. So the person, yeah, Brian. He made it. Is that what you're asking? He survived. Oh, we did dialysis to get rid of all the triglycerides. That's a totally separate thing. I was floored by that. That was crazy. But it was a great teaching case. So like in that, after that, they did like a grand rounds on the effect of like triglycerides and glucose on sodium measurement. So it's one of the stories I tell because it's the way I remember that is these extreme examples, but that's very uncommon. That's the only time I've ever seen anything like that at that level. So in the low osmolality, you have the volume status of the patient. So hypovolemic, euvolemic, or isovolemic, and then hypervolemic. So then you get into why is their osmolality or why is their volume low? So you look at urine. Are they excreting more sodium than normal? So you look at the concentration of sodium in their urine. And if they're excreting more sodium, then you can consider administering sodium or other types of things. But what's kind of neat or what's kind of interesting down here is, so if a person comes in and they have heart failure, so that's the CHF thing right here, these generally will all be true. So the person will have typically hyponatremia, they'll be hypervolemic, and then when we look at their urine osmoles, they'll be concentrated, which is what this urine osmolality is right here. So urine osmoles greater than 100, but their urine sodium is low. So they're not excreting sodium at a faster rate. It's just getting diluted because of all the fluid that's present in the patient's blood. All right, so in summary, questions to ask before deciding how you go about choosing your treatment. You see a low sodium level, you have to start thinking, is the patient experiencing symptoms? Are they in those neurological symptoms? Are they vomiting? Are they in a coma? Are they having seizures? Those are severe symptoms, and that immediately shunts us into one of the other pathways. Look at the glucose. Is the glucose high? Is it low? Is it normal? Look at the serum triglycerides. So that's the thing. So to further answer the question, we would never have measured triglycerides if the blood had not been milky. So the lab actually called and said, this patient's blood, because they typically spin the blood down, and when they pulled it out of the patient, it looked like it was silver, like it looked mixed with blood and the silver components of triglycerides. So the lab actually called and said, well, we went ahead and measured the triglycerides because you wouldn't normally do that unless you had a reason to do it. So then the last thing is you look at the patient's volume status. Are they dehydrated? So what is their ADH secretion? So we'll talk about ADH here in a bit. And are there any other signs and symptoms of volume depletion? So do they have tinted skin? So when you pull their skin up, does it stay up or does it go back down? That's called tinting of the skin. In patients that have low volume, so patients that are hypovolemic, then you would administer fluid, and that will help with their serum sodium level. But as we discussed before, if you have a patient in heart failure and they're already edematous, administering fluid does not help them because it actually might make it worse because they can't get rid of the fluid that they already have. So I mentioned that the first thing that we consider is whether or not the patient's symptoms are acute and severe, meaning did they come on suddenly and are they severe? If they are acute and severe, then you would administer 3% saline, 3% sodium chloride immediately. And that's called hypertonic saline. So I know that that's weird to say just 3% saline is called hypertonic, but that's just the name of 3% saline. So you might see it either way in the hospital. So if that's the case, then administer hypertonic saline. If they don't have those acute and severe symptoms, then you would look at the fluid balance like we talked about before. So if they were over in fluid, then you would consider restricting their fluid and their sodium, because over the course of time they will start to eliminate it if you don't continue to administer it. If they're low in fluid, so that means they're hypovolemic, then you would administer sodium in fluids. And if they perhaps were on diuretics, which is not that uncommon, then you would consider reducing temporarily the diuretic therapy. Or if they had an underlying disease state that was accelerating the activity of the diuretic, then you would consider treating that one. If they're normal fluid balance, so euvolemic, then you would consider a disease called SI-ADH that we'll talk about next, or secondary adrenal insufficiency. So in those cases, you would restrict fluid first, and then consider other treatments like tolvaptan and conivaptan, which I will go over. So as a reminder, those are the severe symptoms that we talked about before. So this is the same chart. I just put it in a different place here. So not to go over that again, but that's the same chart. All right. So one of the things to keep in mind about correcting hyponatremia is that it should not be too rapid. So one of the problems with hyponatremia is that the decline in serum sodium is typically very slow over the course of time, and so the symptoms are either nonspecific or they don't really appear important to the patient. They just think it's something else, or they don't really know that something really bad is going on until it's too late. So the rapidness of the correction is really important. The maximum targeted increase of serum sodium is around 4 to 6 milliequivalents per liter per day, which is very, very slow. Why is that the case? It's because if the sodium is corrected too fast, it can lead to something called osmotic demyelination syndrome. So earlier, when I asked you about like why do people get lethargic, why do people get tired, it's because of the sodium having to do with nerve conduction, nerve transmission. Well, if you increase the concentration too rapidly, then what happens is those myelin sheaths that transmit nerve signals, if you recall, on your nerves, they can demyelinate because of that change of serum sodium being too rapid. So that's just as bad as it sounds, and it's something that practitioners are very, very concerned about when you are correcting serum sodium. So if it's too low, you have to start low and go slow, and the speed is very, very important. So that's why I have the death there. So watch your speed. How fast you correct sodium matters as much as the numbers that you are trying to fix. All right, so SI-ADH is called syndrome of inappropriate antidiuretic hormones. So like a lot of things in medicine, they don't really get too creative with some of these. I'm surprised this one doesn't have a name after someone like all the other stuff that you see, but it's just called syndrome of inappropriate antidiuretic hormone. I remember that because inappropriate means too much, like too much antidiuretic hormone. So it's excess vasopressin activity or excess vasopressin concentration, too much release or increased response to the ADH. Unfortunately, is a diagnosis of exclusion, as lots of other syndromes are. A syndrome is a constellation of symptoms that are present that aren't due to other things. So essentially, SIDH you have to rule out all the other causes on that flow chart that I showed. In low volume, excess mineralocorticoid, all those different things. Heart failure, you have to rule out all that stuff before you can go forward with an SIDH diagnosis. A lot of causes of it. So again, this is from the literature when it comes to like what disease states and what types of things that people have seen that have been associated with these, with hyponatremia. We will focus on the medications part of it, but there are other causes. Acute psychosis is interesting because it has to do with the nerve transmission and some of the issues with that. Malignancy, so typically metastases of like liver and pancreatic cancer can cause SIDH. Severe pain, interestingly enough, can do that. And again, that has to do with the nerve transmission conduction. So in SIDH patients, they will have an over-concentrated urine. And so rather than the normal urine sodium, the concentrations will be somewhere above the 20 to 40 range, which is pretty high. And even when excess fluid is administered, the urine will not dilute. So the urine will be very yellow, very concentrated in solutes. And if you kind of think about it, they're not eliminating their fluid, right? They're eliminating a lot of their solutes. So they might have a normal fluid status. They might not be edematous, but they're eliminating their sodium too rapidly, they're eliminating too much sodium. So once you get into this, the treatment is to restrict free water because you don't want to continue to dilute the sodium that's already there. And typically you would correct whatever underlying issue or disorder is present. If it's the cancer, then you would look towards what the treatments for the cancer are. If it was the psychosis, you would look at what the treatments for that are. The same thing with pain and other types of central nervous system disorders. Water would be somewhere between 1,000 and 1,500 mils per day, which is way lower than what the normal requirements would be. You would possibly consider diuretic therapy, but you have to keep in mind that the diuretics are going to increase the elimination of sodium. So that, as long as fluid goes along with it, that's appropriate, or could be appropriate. And then the medications that we'll talk about on the next couple of slides, the Vaptans. They actually are my second favorite class of drugs because of what they do. But I mentioned that drugs can cause SIDH. So here are the drugs that stimulate the release of antidiuretic hormone. Carbamazepine, antidepressants, some drugs we probably don't use that much, clofibrate and chlorpropamide. Opiates can increase the release of ADH or the activity of it. Drugs that can increase the activity of ADH in the kidneys, NSAIDs. Does anyone know why NSAIDs do that? Remember what NSAIDs do to the kidneys? What? Yes. So you get more fluid going into the kidney. So you're not able to retain fluid as well, but you're also not able to eliminate the other things as well. So cyclophosphamide is a not that commonly used drug, but it increases the activity of ADH in the kidneys. And then, so what do all these things have in common? They mess with neurotransmitters. That's one thing. They also mess with kidney function. In the form, in particular, of the NSAIDs. So there's a lot of neurologic medicines that are on here, and also a lot of neurotransmitter-related medicines. So ecstasy is MDMA, and that has an effect on brain chemistry as well. So I mentioned the Vaptans. They're vasopressin receptor antagonists. So as I said before, if the SIADH is due to too much vasopressin, then a drug that blocks vasopressin activity would be phenomenal. And that is exactly what the Vaptans do. So they are vasopressin receptor antagonists. So the mechanism of action, this is normally the V2 receptor. So the V2 receptor, vasopressin sits on it, and it increases the water permeability. So if you have a drug that sits on it, it will block the block the excretion of free water, and lead to higher sodium concentrations. So you're not going to eliminate as much sodium, but you're also going to excrete more free water. So they do exactly what we want them to do. That's why I like those drugs so much. They don't do anything different. They do exactly what we want them to do. Here's another caveat, though. We're talking about drugs here. Conivaptan is available IV, and tolvaptan is available PO. What did I say was the challenge with treating hyponatremia? What do you have to be most concerned about? How fast you're doing it. So the rapidness of it. Now, oral drugs are great, right? But you can't take back an oral drug. Once you give it to the patient and it's absorbed in their system, it is there. It's going to be there. So Samska, or that's the brand name for tolvaptan, is an oral drug. It's administered typically once a day. But because of the issues with increasing serum sodium, you actually have to give it in the hospital. So it doesn't necessarily, you will likely not dispense it at your pharmacy ever unless you're working at a hospital pharmacy because of that restriction. But it does then have limited efficacy or value, because if they're already in the hospital, what's the difference between getting an IV form of it and a PO form? Yeah, Austin. No, it just lasts longer. But the benefit, so Conivaptan has a dosing duration of somewhere between 72 and 96 hours. So you're giving it continuously over that time, but you can stop the infusion. So if you give Samska or you give tolvaptan, you can't stop that infusion because it's already in the patient's body. So they give a dose of the drug, wait 6 hours. You have to get labs pretty frequently. You're basically doing the exact same thing that you would do if you were giving an IV. So when that drug came out, I think that the company that sponsored it thought it was going to have a better market. But when you get into the logistics of it from a safety standpoint, there wasn't anything different that we would do for the patients giving an oral drug versus an IV drug. So The only thing is if they didn't have IV access, they wouldn't have to get IV access. But I think they would probably already have it if they were in that setting, because you might need to administer other IV fluids to the patient. So, all right, switching gears to hypernatremia. So instead of low sodium, this is high sodium. It's typically rare in patients that have intact vasopressin secretion, because anti-diuretic hormone is designed to block diuresis. So if you have a functioning brain and functioning set of kidneys and also access to free water, you're typically not going to get too much elimination of water. As you get further up into the sodium ranges, so you're looking at normal range is 135 to 145. As you get closer to like 160, you get into really, really severe risk of life-threatening symptoms. The mortality is increased by over 75% above 160. So causes of hypernatremia, as I noted before, inability to obtain or drink water. So patients who either can't drink water or they don't have water, they can get hypernatremia. If you are feeding someone enterally, which means through a tube feeding that doesn't have enough free water in it, it's the same as not drinking enough water. When you get into nutrition later on, you'll talk about, when someone's getting either TPN or enteral feeding, they're not drinking water, right? Because you're not giving it to them and they are otherwise unable to drink it on their own. So looking at the free water in enteral feeding is really, really important. In the same way that us drinking water, us ambulatory people drinking water is really, really important. The other cause is something called diabetes insipidus that I'll talk about in the next couple of slides. And other diuretic, like persons overusing diuretics, that can cause hypernatremia, or people taking salt tablets because that's available. They could just be eating salt or taking salt tablets that could cause hypernatremia also. And that's more logical. So just like in the hyponatremia, you do look at fluid balance. You look at overall fluid balance for the patient. So you can be hypo, hyper, or isovolemic. And that has to do, again, with the relative concentration of the sodium versus the water that's present. So if you have the loss of water and sodium, that can be due to kidney function, adrenal function, GI, lung, or skin, because you're losing fluid that way. You could gain fluid and gain sodium, so you're hypervolemic, but you also have too much sodium present. And so that could be caused by taking those salt tablets I was just mentioning, so sodium overload, or mineralocorticoid excess. You recall mineralocorticoids are part of a steroid that causes fluid retention, and that can be one of the things that leads to it. And then isovolemic hypernatremia is pure loss of water. And so that's the kind of big glamorous disease state that has to do with hypernatremia. So diabetes insipidus is one of those disease states. And again, I've got some stories of just how I discovered or how I learned about these things. So what would happen is, in a trauma setting, we don't know a lot of what's going on with the patients. We have to learn about them as they progress through therapy or progress through their treatment. So what would happen is I would go in the morning and we'd be talking to the nurse, and you would see that the urine bag on this patient was emptied like an hour ago, and it's already filled with what looks like water, what looks like pure water. And that is large volume of dilute urine. So what's happening in that circumstance is the patients are not retaining fluid. They are eliminating fluid and they're retaining the salt. So they're losing free water. So urine osmolality is the diagnostic characteristic that is most significant here. Less than 200, 300 milliosmoles per kilo, usually diabetes insipidus. So normally that is 500 to 800 milliosmoles per kilo. When you're looking at classifying DI, there are two types, central or nephrogenic. Central is where your body is not releasing enough ADH, and nephrogenic is where the kidneys are not using ADH appropriately to concentrate the urine. So a large volume of dilute urine is a clue to think about diabetes insipidus. So what do I mean by light urine? This is something, if you haven't seen this is really common in practice. So how do you classify your urine? These are like the colors that urine should be. So what do you think your urine should be color-wise? Which number? Hopefully in the middle of that range, right? Otherwise it wouldn't be that. So yeah, 3, 4, but you could, so this is over-concentrated and this is dilute. So that is a very helpful way for us to distinguish between the different types of classifications for urine. So patients should have aggressive free water replacement with a close monitoring of urine output and serum sodium. They also may require vasopressin administration or replacement. Why is that? It isn't always that they need that, because if they had nephrogenic DI, then the kidneys can't use the vasopressin even if you gave it to them. So what happens in those circumstances is you would try. So we've done this before. You try DDAVP, you try a small dose of it, and if it works, so they start decreasing their urine output, if their urine osmoles increase, then the patient is responding to therapy, and that's central diabetes insipidus. And so we can continue to administer DDAVP for who's dispensed DDAVP? Ever dispensed it? Because what other disease state is it used for? What do you see it most common for? Yeah. So most common is for bedwetting in kids. And so if you think about it, it blocks the release of fluid into the urine, right? So like your kidneys are not producing as much urine, so you're concentrating your urine, which is what you're not doing when you have DI. So in kids, it doesn't really have to do with the bedwetting itself. It has to do with them not having urine to make overnight. So what they would do is they'd give it to the child overnight until they're able to train out of that, whatever it is. And that's more of treating the consequences of the condition versus the condition itself. But that's where you might see it more often. It has a nasal spray form, and that's used more frequently in kids because tablets are sometimes difficult for kids to take. All right, so treatment or correction of hypernatremia. This is one of those times where you would actually this is not one of the formulas I want you to learn, but what you're looking for here is if you've ruled out all these other causes. So if, let's say, if it's something that, their enteral feedings don't have free water in them and you change the feedings, that's treating the underlying problem. But let's say that it's something that is not able to be treated otherwise, then you would calculate what is called the water deficit. So based on the sodium, how much fluid are they missing? Or how much fluid are they deficient of? And so that is the total body water, which is around 0.5 or 0.6 times your actual body weight. And that then you multiply that times basically a factor of your serum sodium over 140. So if your serum sodium was 160, so it'd be like 160 minus 140 over 140 would give you the factor of increased sodium. And then you would multiply that times the total body water. Once you do that, you can know how much water that needs to be replaced to correct that sodium, and you would replace half of that deficit with some kind of hypotonic fluid. And this is one of those circumstances I told you before. You don't very commonly see hypotonic fluids, but this is one of the times where it might be something that you would reach for. So you'd replace half of that deficit over the first 12 to 24 hours and replace the other half over the next 24 to 48 hours. So unlike hyponatremia, you can correct hypernatremia faster than hyponatremia. So the goal decrease of hypernatremia would be about 10 to 12 milliequivalents per liter per day. Yeah. Okay, yeah, the question is there a preference in the choice of the hypotonic fluid? You would look at what else is going on with the patient. So you look at whether they're eating, whether or not, because if they're eating, dextrose is not fantastic for them because they're already eating something. If they're able to drink water, then they're not typically restricted in that way. So you would just consider the other factors. Half normal saline I would see more frequently because it's something that the patients can easily get rid of or easily eliminate. But you're not doing it as fast as you might do it if they were critically ill. Like you're not giving it over an hour, you're giving it over 12, 24, 48 hours. So that's something that the kidneys can typically accommodate for. So it really does depend on the underlying factors for the patient. All right, so switching gears to potassium. Unlike sodium, potassium is the most abundant cation in the intracellular fluid. And so it balances out sodium. So we talked about before nerve conduction, right? Sodium goes in, potassium goes out. Sodium goes in, potassium goes out. That's what's called a gradient. And so if there's an electrolyte gradient present, then you can have transmission of nerve signal. So you need a sodium concentration that's higher on the outside than it is on the inside of the cell, and you need a potassium concentration higher on the inside than it is on the outside. Otherwise, there's no gradient for those electrolytes to cross. Um, we do actually have to consume potassium in our diet. So it's not like it's one of the essential amino acids like you might have learned about in biochemistry, but we have to eat it. So we need somewhere between 40 and 80 milliequivalents of potassium per day. We tend to get that already. Even most processed foods are fortified with potassium in them, but as you probably recall, like bananas have potassium in them. A lot of multivitamins have potassium in them. So potassium's pretty commonly used in life. It's pretty common to be in our diets. So, unfortunately, though, the measured serum sodium that we get in the lab values is not the total amount of sodium we have, because most of it is not inside, or so most of it is not in the intravascular space. It's inside of the cells. So the stores of potassium are what we really are concerned about, because potassium can distribute outside of the cell, like it can leave the inside of the cell and come outside the cell to balance out the concentration, but that's a lot slower of a process. The measured serum sodium is affected by the intake of it, as I noted before. You lose potassium in like diarrhea fluids or in vomit, and aldosterone is a hormone that it affects fluid balance overall, and also acid-base balance can affect serum sodium. So I have up here the normal ranges 3.5 to 5. I don't know if this has changed, but when I was at Baptist, the normal range was 5.5. That's okay. Like use whatever value your hospital says is, or the place you're working says is normal, because the difference between 5 and a 5.5 is not that dramatic as it is between 5 and 8 because of what happens. So looking at hypokalemia is low potassium, and it is pretty rare in healthy individuals. So hopefully, since all of you are here today, your potassium is not out of whack. I don't know that, but that's my guess. But in the hospital setting, because of the same reasons we talked about before, the patients have a lot of other things going on. You don't get otherwise admitted to the hospital unless you have, some kind of underlying disease state. It's really, really common in the hospital setting. So what we do, so before the development of protocols, most of the interventions I made in the mornings in the ICU were correcting electrolytes. So correcting magnesium, correcting calcium, correcting sodium and potassium. Symptoms are often asymptomatic for mild, but moderate, which would be, I'll get to the distinction between that here in a bit, but you would get into like muscle issues, so cramping, weakness, malaise, and myalgias for moderate hypokalemia. Again, it's rare in the community setting, but pretty common in the hospital setting. So working in the hospital, you will see hypokalemia. How much to replace? Now, this is another rule of thumb, but it's something that I have not seen anyone not know in the hospital setting. So you would expect about a 0.1 to 0.15 milliequivalent per liter increase in the potassium level for every 10 milliequivalents given. So that is not always exact because of other factors that are going on with the patient, but it does help you decide what approach to take with that. So most inpatient facilities, hospitals, long-term care facilities, they'll have protocols, and I'll show you an example of a protocol here in a bit. But one of the things about the protocols that can be something that maybe not is captured on the protocol is that there are often other electrolytes along with the K. So it's either potassium citrate, potassium chloride, or other type potassium gluconate. That other thing that it's formulated with can be some other non-potassium salt that just has to be administered with the potassium. So another example is potassium phosphate. So if you had phosphate that's high, let's say the patient's in renal failure, you wouldn't want to give them potassium phosphate because phosphate is not able to be eliminated as rapidly in someone that has renal failure. Another aspect that's important is liquid oral supplementation. So like potassium in liquid form is often formulated with artificial sweeteners, and artificial sweeteners can lead to diarrhea. Diarrhea causes excess elimination of potassium. So I've seen situations in which patients are chasing. So they give potassium orally in through the feeding tube. It's a liquid. It causes diarrhea, which causes the elimination of more potassium that leads to more potassium being administered. So that is what's called a prescribing cascade. And it is very difficult to stop. The only way you stop it is you stop administering the potassium. So in those circumstances, what we do is tend to switch to powders as opposed to the liquid because there's less artificial sweetener in those. If you're giving it through a feeding tube that's bypassing the mouth, you don't need an artificial sweetener because you're not going to taste it. Why it has artificial sweeteners is that it's very bitter. So if you were giving it and the person like bites down on the tablet or has the tablet in their mouth, it's going to be very bitter for them to take. So that's where the liquid supplementation comes in. So that's why I have a little caution there that it's kind of an insensible loss in the sense of like, why is this patient's potassium continuously lower even though we're continuing to give it to them? And that could be something that, pharmacists can make a pretty good intervention on. Here's an example replacement protocol here. So if you look at the way it's broken down, you have potassium less than 4. That's the cutoff for when you start to consider the protocol. Then you look at the phosphate. So the phosphate is either above 2.5 or lower than 2.5. If it's above 2.5, then you would give potassium chloride, which is what this chart is. If it's less than 2.5 or equal to 2.5, then you would give potassium phosphate. And that actually goes to a different protocol in this example. So potassium phosphate is, also administering phosphate along with the potassium. So in this case, if you're giving potassium chloride, you would look at the serum K, and then you would decide how much you give. So the lower the potassium level, the more potassium you would give, but you have to give it over a longer period of time. And so that's where this maximum rate of infusion comes in at the bottom. So I don't want you to memorize that. That's a protocol, but it has all the stuff we've talked about on it. It has the considerations of the rapidness of the administration. It has what other values you look at, which in this case would be phosphate, and it also has oral versus IV on it. So in looking at the oral treatment options, the prescription products, there are OTC potassium, which I'll get to at the bottom of the slide. The most common prescription replacement product is KCl, or potassium chloride. You will see lots of different brand names of it. So this is one of those that, especially like working at a drugstore, I never really knew what the difference was between all those, but it really has to do with the branding of it. So like micronized versus like extended release versus like easy on the stomach, not easy on the stomach. Those are all different things that are probably difficult to decide between. I can't sit here and tell you one is better than the other, but there are immediate and extended release forms. I would say the only caveats to that is if it's an extended release form, then the patient shouldn't chew it, right? It can't be broken up into split or put, into enteral feeding or whatever. So K-Tab, Chlorcon M10, Chlorcon 10, all those are different brand names that are out there. Non-chloride salts do contain a lot less potassium, so efficacy-wise, you're going to have to use more of them or the treatment will be for a longer period of time, but they're much less irritating. So they have much less like GI effects from the drug itself. So potassium citrate is just as effective in terms of its efficacy over the long term, but it breaks down to bicarb. So citrate is a base, and so it breaks down into bicarb and can affect acid-base balance. That might not always be a bad thing though, because if they were acidic, if they were acidotic, then you might want to administer bicarb. Potassium phosphate, as I noted before, also co-administers phosphate, so helpful if the phosphorus also needs replacing. The OTC potassium products include gluconate, so that's the one that you see most often. If you go to Walmart or CVS or Walgreens or whatever, on the shelf, you'll see bottles of potassium gluconate. It, as you might imagine, contains far less potassium molecular weight-wise or just quantity-wise, milligram-wise, than it does in the prescription product, but it is available as a supplement. And foods that are high in potassium, the hyperlink there is to this New England Journal of Medicine article from 1998. They did an assay to figure out how much potassium is in certain types of food. So that's where the idea of like every inch of a banana contains 10 milliequivalents of potassium, which is something I've heard for a while. Not really sure that that's the case, but it came from that particular study back in 1998. So in terms of the potassium chloride formulations, we do have a choice between IV and PO. So IV is reserved for severe patient, severe symptoms, or in a severe hypokalemic state, which is typically less than 2.5 milliequivalents per liter. Keeping in mind the normal range is 3.5 to 5. So it doesn't seem like 2.5 is much lower, but you don't have that much further to go. So you would reserve IV for those situations, or if the patient is unable to take foods by mouth or to take anything by mouth. So it is preferable to have a central line. And did y'all talk about central versus peripheral IV access? Okay, so I didn't know, so that's why I put it in here. Central, what is a central line? So central venous catheters typically go directly into the inferior or superior vena cava, which is a large blood vessel. It's in the venous system. The peripheral line goes into a small blood vessel. So the difference is the size of the blood vessel that the catheter goes into, because if it's smaller and it causes irritation or phlebitis, it can actually blow the vein, and it can cause a lot of pain for the patient. So a central line is preferable if infusing a higher concentration of potassium, because that's more potassium per unit volume, and that causes more irritation to the veins. So if you're infusing a higher concentration than 10 per 100, then you would prefer a central line in those cases. I have this in here because I was always confused about this when I was in school, where you are, but these are bags of potassium. So unfortunately, they all look kind of the same, don't they? Well, that's unfortunate. That's not really good from a safety standpoint. This is 10 per 100, which is 100 milliequivalents per liter. This is 20 per 50, which is 4 times the concentration, even though the volume is only half. That's 4 times the concentration. This is 10 per 50, which is 200 milliequivalents per liter. And this is 20 per 100, which is 200 milliequivalents per liter. So a bag, so those bags may look the same, but they're very, very different in nature. They're very different in what you and how you would give them also. This is probably one of the most important safety things about this material, because hyperkalemia, so potassium, is one of the ingredients in lethal injection. So I've written several papers about lethal injection, and it is one of the ingredients in the cocktail for killing someone, because it will stop your heart if you administer it too fast. So switching to talk about that, hyperkalemia, it can be caused by excess intake of potassium if you shift it from the intracellular to extracellular space, or when patients have diminished renal function. They're not able to eliminate potassium as rapidly. When you get into the symptoms, you're actually looking more closely at heart conduction, which is the segue to it will slow down or stop your heart. Abnormal cardiac conduction starts when the potassium hits that 5.5 to 6 range. So you start getting the potential for changes in cardiac conduction. You start to get peaked, narrowed T waves, which is on the picture up there at the top. That's what that looks like, really high peaked T wave. Widening of the QRS interval, and that can eventually lead to ventricular fibrillation and asystole, and that's how it's a part of lethal injection. It's also extremely, extremely painful. You can get muscle weakness or paralysis when the potassium hits somewhere between 7 and 8. So this is what this looks like on an EKG or an ECG. So tinted T waves, loss of a P wave, so the little P that's there, you start to lose it. Then you get a widening of the QRS interval. Then you get to, that is a sine wave pattern, and this is VFib. So that is something that is a shockable rhythm. If you remember from ACLS or somewhere around there, it's shockable, but it is also not sustainable. So a person that is in that is not going to be long for the world. The treatment philosophy is one of two things. Either you have a non-urgent approach, which is non-life-threatening, and you're just trying to get rid of the potassium from the body because you've got time. Or you have an urgent approach, which is when you don't have a lot of time and you need to shift potassium inside the cells. Because if it's inside the cell, it's not going to cause death as rapidly as it would if it were outside the cell. So we'll start with the non-urgent. For non-urgent care, so this is a patient without symptoms and the potassium is less than 6.5, then you would consider a cation exchange resin. And what that does is it binds potassium. It's also called a potassium binder, and then it eliminates it from the body. So the example and kind of the prototypical one of these is K-exolate. So K-exolate, K-exit. That's how I remember that one. Exit K from the body. Caxylate is also known as sodium polystyrene sulfonate. So that's what you'll see it as. It used to be branded. It would have Caxylate on it and have a trademark, so it's easier to see. But sodium polystyrene sulfonate, and then this is the suspension, and this is another form of it. So it is available in a rectal suspension as well. So you can give it, if the person can't take it by mouth, they can administer it as an enema. But one of the things that is actually a feature of it as opposed to a defect of it is that it can cause diarrhea. So diarrhea removes potassium from the body. That's one of the things we talked about before. So it is not necessarily a bad thing to have diarrhea in those circumstances because it does help eliminate the potassium. So lack of symptoms and a relatively moderate elevation of potassium means that you have more time to treat it, and that's where you would use these resins. All right, so since I first started teaching this, we do have other alternatives to SPS that are out now. I do have a note here that the use of this will vary by the facility that you're in. So you may be at a hospital that does not carry either one of these products, or you may be at a hospital that only carries these products. The data behind both of these is stronger than the data behind Caxylate, but they are much more expensive. So that's a trade-off between the cost of them and the consequences or the side effects of them. So one is sodium zirconium cyclosalicylate or cyclosilicate, sorry, and that is SCZ or low Kelma. Again, low K, lower potassium, or Patirimer is the other one, and the brand name of that one is Veltassa. So these are both still patented brand-only products, and you may or may not see them. Some hospitals, like I looked at the formulary for Baptist before I left, and we didn't even carry either one of these. We just carried Caxylate, but that may change in the time that you all are practicing. So shifting away from the non-urgent treatment to the urgent treatment. In an emergent situation, either symptomatic, so severe muscle weakness, the potassium's over 6.5, or if they've already experienced EKG changes or ECG changes, then you would slot into this urgent treatment. So what you do first is you protect the heart through administering calcium, and calcium lowers the energy that is required to propagate the heart rhythm. So that's why you would administer it. It has nothing to do with the potassium. It has to do with protecting the heart. And then the next step is to administer drugs or administer substances that shift potassium inside of the cell. And in this case, one of the questions that you have to ask, or one of the things you have to know, is whether or not the patient has central or peripheral IV access. I'll tell you, in the hospital, that's pretty well known. Like the nurses will know what kind of access the patient has because they're always looking at the lines. And so I remember going and saying like, hey, does he have a central line, or what kind of lines do you have on that patient? Because you want to know what all is infusing. They might be getting antibiotics at the same time, and so you might have to figure out the IV compatibility, whether they're Y-site compatible or same line compatible. Do y'all remember that? Did you talk about that in sterile dosages? Y-line, or okay, Y-site compatibility. Okay. Yeah, Trissels. Yeah, good stuff. All right, so this is an acronym that everyone in medicine knows. So your med school people, your nurses, everybody knows. It's called C big K drop. And so this is the urgent treatment of hyperkalemia. First is the C, which is calcium. So calcium, typically gluconate, but it could be chloride if the patient has central IV access, but most of the time it's gluconate because it's useful in both if they have central or peripheral. Then you would give bicarbonate, typically IV in the form of sodium bicarbonate, beta agonists, so albuterol. You could actually administer in the EU. They have IV albuterol, which works the same way. It's an IV beta 2 agonist, but that causes a drop in potassium by shifting it inside the cell. What I see in the States is they put a nebulizer on the patient and it administers albuterol that way, so it goes into their nose and into their lungs, and it gets absorbed that way. Insulin and glucose go together, so insulin drives potassium inside the cell. Glucose corrects the glucose, so you have to give the insulin with the glucose, otherwise the patients will get hypoglycemia. Caxylate is that K, or other Patirimer or sodium zirconium cyclosilicate. That is the K part, and then drop is dialysis, diuretics, and then the word drop means lower it. So C big K drop is the acronym that kind of covers all of your bases when it comes to lowering your potassium level. I have a note here that calcium chloride provides more elemental calcium versus the gluconate form, but it is much more irritating, and so it requires central access, and it requires it to be not administered with other things. So if you're giving it with potassium chloride, calcium chloride can precipitate with bicarbonate. So if you have something that has bicarbonate, especially if you were giving it already, then it will form chalk. So that's not good. And so it actually, I used to do it in the IV room where I would mix the bicarb with the calcium chloride. And you could see the white form. You could see the precipitate form in the bag. I use that to teach that, but you don't want that to happen inside the person, particularly if they're already experiencing the symptoms of hyperkalemia. All right, so I found this site that had these cool graphs. So it's got hypo and hyper, so the causes, the signs and symptoms, and then these like characteristic of the disease state. So that might help you, but it's got all the same information that we talked about before. All right, so the formulas you need to know. Estimating plasma osmolality, that's 2 times sodium plus glucose over 18 plus BUN over 2.8. The adult fluid requirements rule of thumb, and the pediatric fluid requirements, the Holiday-Seeger method. So, any questions? All right, thank you all. Who's next in here? PK, that's right.
What's your favorite lecture to do us?